All right, let's go ahead and get started. Well, hello, everyone, and welcome to today's Present Approaches to Testing webinar. When is it cool to drool? Oral fluid testing for controlled substance monitoring. I'm Dr. Linda Hasatsri, the director of the Molecular Technologies Laboratory and a consultant within the Division of Laboratory Genetics and Genomics at Mayo Clinic, Rochester, in Minnesota. And I have the honor today of introducing our presenter, who is, although he would never admit it, quite a legend in the field, Dr. Paul Janetto. Dr. Janetto is a co-director of the Clinical and Forensic Toxicology Lab, the Metals Lab, and the Clinical Mass Spectrometry Lab, as well as the Vice Chair of Practice for Laboratory Medicine at Mayo Clinic in Rochester, Minnesota. Before we have him begin, though, just a couple of reminders. There will be a question and answer session at the end of the program. You can submit questions online via the handy Q&A link at the bottom right in Zoom. Please only use the chat function for any technical issues you may be having. Today's program is being recorded and will be posted to our website in a few weeks. And also a copy of today's presentation slides will be available following the webinar. And with that, I will now turn things over to Dr. Janetto.
Well, thank you very much for that introduction. And good morning, good afternoon, or good evening, no matter where you are. It's an absolute pleasure to be here today to talk to you about oral fluid testing for controlled substance monitoring. And so we're going to find out, when is it cool to drool? I do have no financial relationships or off-label usage to be discussed in this presentation. What I do hope is that after this session, that you will be able to describe substance use disorders and actually define what is oral fluid. I also want you to be able to understand and identify the advantages and limitations of using oral fluid as a matrix for controlled substance monitoring. And lastly, we'll talk about how to correctly interpret oral fluid drug testing tests. So let's get started. First of all, what are substance use disorders? And these are really, it's a disease that affects a person's brain and behavior, and it leads them to an inability to control their use of either a legal or an illegal drug or medication. And unfortunately, last year in 2024, we had over 45 million American adults, that's about 18% of our population, who battled a substance use disorder. So this is not uncommon. And substance use is really this chronic repeating pattern where people are excessively abusing a substance in a way that's harmful to their own health and well-being. Of course, this can lead to addiction. Addiction is another chronic but treatable disorder that is characterized by that compulsive need to use either drugs or even drink alcohol despite those negative consequences. And addiction can be both physical and psychological. And with this, you can also get to dependence. And dependence is that physiological reliance on that drug that develops through that chronic reoccurring misuse of an illegal or legal substance. Now, today we're going to talk about the laboratory testing for substance use disorders. And it's important to understand that laboratory testing plays a very important role in substance use disorders. And according to the American Society of Addiction Medicine, urine lab tests are actually used to assess drug use. But remember, our tests are not diagnostic tests for addiction. In fact, drug testing should never be relied upon as the sole measure of a patient's substance use. Despite that, they do recommend that you use laboratory testing throughout the addiction treatment setting. So when you first have your initial assessment with a new patient, and then as you monitor the effectiveness of their treatment plan throughout the rest of their therapy. A key is that these lab tests are really being used to guide and monitor the patient's treatment and recovery as part of their routine medical care. We never, ever should laboratory tests be used as a punitive measure. These are really meant to provide support and actually provide motivation and reinforcement so the patient remains abstinent. And one of the phrases that I like from the American Society of Addiction Medicine is that they say drug testing is really the technology of addiction treatment. In their consensus statement, they also go on and talk about some examples of inappropriate or costly drug testing practices. And so in laboratory medicine, we want to have proper stewardship and use the proper use of our tests. And so one of the things that we don't want to recommend is just using large arbitrary drug testing panels where you're just testing hundreds and hundreds of different drugs. You also want to look at the frequency of ordering tests. We don't need to order tests 7 days a week on patients. The other thing that they go on to point out is that you don't always need confirmation or even quantification, so getting a concentration of all presumptive positive or negative results. Remember, at the end of the day, the goal is not to identify every single drug technologically possible, but to do medically necessary testing for those drugs that most likely impact the patient outcome. The American Addiction Society also goes on and gives really good examples of, well, what are appropriate then drug testing or laboratory test practices. They recommend that you choose drug testing panels that are based on what that patient's drug of choice is. So what have they used in the past? If they're a known heroin addict, obviously heroin is something you're going to want to check or test for. Also, since you're testing for compliance or adherence, what other medications that are being prescribed or other commonly abused drugs in that geographic area? Providers also really need to understand the advantages and the disadvantages or challenges of each matrix before considering rotational strategies. And one thing that they recommend, and we'll be talking about today, is presumptive testing. And presumptive testing should be a part of that routine, ongoing, both the initial and ongoing patient assessment. However, you also supplement that with some definitive testing using more confirmatory test methods, especially when those presumptive tests may not agree with what the patient's being prescribed. At the end of the day, when you get your laboratory test results back, the providers really need to consider all the relevant factors around the case before making a decision solely on a single drug test. And this is where we recommend that you consult your laboratory or other medical review officer for guidance with interpretation, because the laboratories understand and characterize their tests and can help you interpret those results correctly. And lastly, the frequency of testing should really be dictated by the patient acuity and level of care. So typically this means at the beginning of the treatment phase process through addiction management, you're going to be testing a little more frequently. And then as the patient, is being successful and adherent to that program, it can occur on a much more random and less frequent basis throughout the remaining course of treatment. Now, I'm not going to lie to you. Laboratory testing for controlled substances is a very challenging thing for people to interpret. And there's lots of different issues or challenges with laboratory tests, starting with, first of all, what type of test should I be doing? Should it be a point of care test? Or should I be using laboratory-based testing? What specimen matrix should we use? Today we're going to be focusing on the use of oral fluid as an alternative testing matrix. Do I always need to get a quantitative test with a concentration, or should I be using the qualitative, the presumptive positive, or not detected type testing? An interpretation of these test results obviously can be very challenging, also depending on what type of test we order. Well, was this just a screening assay or was this a definitive assay? And as you get into these medications, a lot of these have very complicated metabolic pathways that clinicians need to understand when interpreting results, as well as our technology and our instrumentation become more sensitive and we have lower detection concentrations, we can even pick up pharmaceutical impurities. All of this makes it very challenging sometimes for a clinician to properly interpret a laboratory test result. And then you have still the decision, if I'm only doing a screening test, well, do I have to confirm or do additional testing every time? And then, of course, How does this impact our patients? And is there reimbursement for these types of tests? So let's start to go through some of these issues and address some of these in this presentation. Starting with what specimen matrix is best? Well, one of the most common used matrices is urine, and that's for many reasons. One of it is it's non-invasive and relatively easy to collect. Urine also gives us a pretty good detection window, meaning that window of time where you can detect when did they last use that drug. The disadvantage, though, is most of the urines that are being collected today are not witness collections. These aren't typically workplace drug testing type collections. As a result, it's very easy to adulterate or substitute somebody else's urine for your urine. Alternative matrices like serum are great because they also have a shorter detection window, and so it's more recent usage. However, obviously you have to have a phlebotomist draw a sample, so that makes it a little bit more challenging and an invasive procedure. Today, we're going to focus on oral fluid, which again is another non-invasive technique and a matrix that we can use to look for controlled substance monitoring. And the nice thing about oral fluid, unlike urine, is that the collection process is easier and you don't have to worry if you are doing, in this case, witness collections, don't worry have to worry about gender issues between the collector and the collectee. However, like all tests, there are some challenges with oral fluid in that detection window, again, is going to be shorter, reflecting that more recent usage, and you're going to mainly see parent drug. In this graph, we kind of see a summation of the different matrices, serum and oral fluid having similar sort of windows of detections. So in these two matrices, we typically see drugs that are taken within the past 24 up to 48 hours, depending on the drug. Urine, again, I said, has that sort of bigger or broader detection window where it can be several days, even up to some weeks, depending on the half-life of the drug. And then we have alternative testing, which we don't commonly see for controlled substance monitoring, like sweat, hair, or nails, which can give, again, even longer windows of detection. But now I want to focus back to our topic today and really address the question, is oral fluid really a good alternative to urine for controlled substance monitoring? And if you look at most clinical practice guidelines, you will see that urine is one of the recommended and preferred matrices for testing patients for controlled substances. And that's both in a pain management population and an addiction medicine population. Again, because it's non-invasive and has a good window of detection. However, if you also read in these documents, for example, in the laboratory medicine practice guideline document, they actually state oral fluid is an acceptable alternative to urine drug testing. And it is widely accepted as an alternative matrix for controlled substance monitoring. However, there are two important differences that I want everyone to walk away with today. Is that in oral fluid, drugs are detected sooner, so they appear sooner in oral fluid compared to urine. And at the same token, drugs are cleared faster in oral fluid compared to urine, meaning the window of detection is going to be shorter in oral fluid compared to urine. So now let's get into the facts. What is oral fluid? Well, it's actually mixed saliva that is produced by three different glands, the submandibular, sublingual, and parotid glands. It's a clear, watery fluid that's mixed with gingival curvicular fluid, cellular debris, bacteria, and yes, the remnants of your last meal, so ingested food products. It is slightly acidic, so it has a pH somewhere around 6 to 7.8, which actually in some cases helps us because it can trap some of our basic drugs that we'll talk about in a little bit. And most importantly, we are drooling machines. We actually produce up to 1.5 liters of oral fluid a day. Now, some people interchangeably use the terms saliva with oral fluid. However, technically, they are slightly different definitions. Saliva refers to fluid that's collected from a specific gland, so just one of the glands that's free of those other materials that we talked about. And saliva plays actually an important role in our biological process in that it actually does lubrication, helps with digestion, and host defense. Oral fluid, though, as I already mentioned, is the mixed saliva from all the three glands, along with those other, quote, constituents, right? That gravicular fluid, the cellular debris, bacteria, and that food products that's remaining. So we're going to be talking about oral fluid testing today. And why can it work for controlled substance monitoring? Well, first of all, you have to understand that the reason it works is because the drugs that a patient's taking can actually get into our oral fluid. And there's two primary mechanisms that occurs. One is just by passive diffusion. So oral fluid is really considered an ultrafiltrate of our plasma. And that is the main mechanisms that drugs are going to cross into the oral fluid. And that's going to obviously vary on the different drugs. Again, acidic drugs, basic drugs, their lipophilicity. Again, that salivary pH can actually help some of our basic drugs that then go in and become ionized or trapped in our oral fluid. So we actually see some higher concentrations of those drugs in our oral fluid compared to serum. And the amount of protein drug binding will affect how much that drug crosses over into our oral fluid. The other way that drugs can end up in oral fluid is obviously through the direct use of that drug. So some drugs people might either inhale, smoke, or swallow, right? Because you're putting them directly into your oral cavity, you will obviously have some direct contamination, right? The residual part of that drug can incorporate into the oral fluid through that direct deposition process. Now, when we talk about collection options for oral fluid, there are two primary different methods for collecting. One is what's just considered neat oral fluid. This is just where you're essentially spitting or drooling into a container. This is obviously the least expensive method. A lot of the workplace drug SAMHSA cutoffs are expressed in these concentrations. However, the problem with this is sometimes it's hard to actually collect adequate volume. People have dry mouths, smokers, etc. And more importantly, some of the analytes that we test for example, THC, are actually just less stable in neat oral fluid. As a result, another method is using a collection pad, either with or without a stabilizing buffer. Now, the advantages of these collection pads is obviously they can help eliminate some of those residual food particles and cellular debris. But it can actually help that collection time a little bit faster than just drooling passively. And then if you use a buffer, a stabilizing buffer with that collection pad, obviously that can help stabilize some of those drugs that may not have good stability over ambient or refrigerated conditions. It also prevents bacterial growth and reduces the viscosity of oral fluid, making it easier for us to analyze as well. So what are the advantages of someone using oral fluid over another matrix? Well, as I started out and alluded to, it's non-invasive, right? It's very easy to collect. We are all drooling machines, as I told you earlier, producing up to 1.5 liters of oral fluid a day. You also can do direct observation, and you don't have to worry about gender issues. In several studies, we also see that patients preferred giving an oral fluid sample versus giving a urine sample. The advantages also, as I said earlier, is it reflects more recent intake. So I have to be using it within the past 24 to say 48 hours for most drugs. This chart just summarizes some of the average detection windows. Again, these are average detection windows for the various drug classes. But again, for most drugs, you'll see this is around a 24-hour, sometimes up to 2 days or longer, depending on the drug and the half-life of the drug. So it does vary by the drug. The other advantage, though, of oral fluid is, unlike urines, right, it's harder to adulterate, especially if you're doing a witnessed collection, right? Because I'm going to be collecting that right in front of you. And we have commercially available collection devices, as well as even some FDA-approved assays for some of our analytes. Now, like all matrices and all lab tests, there are challenges that you need to be aware of as well. One of them is that in that collection process, since we're not doing 24-hour oral fluid collections, right? These are typically short-timed type collections, is that volume is going to be limited during that collection period, right? Recovery of drugs, right? Some collection devices vary in recovery for different classes or different individual drugs. And not every single drug is always detectable in oral fluid. As I alluded to earlier, basic drugs, things like oxycodone, hydrocodone, etc., fentanyl, they actually accumulate in oral fluid and tend to actually be at higher concentrations in oral fluid compared to serum. However, conversely, more acidic drugs, benzodiazepines, and others, or high protein bound drugs, actually may be present at lower concentrations in oral fluid compared to serum. And we also still have to worry about things like smoked, inhaled, or ingested drugs, which can contaminate and lead to increased detection rates. As I mentioned, the detection window of drugs varies in oral fluid. So it's important to know what drugs you would find in the past window of detection for that drug. And even though I said adulteration is hard, you still have to be aware of methods to alter drug concentrations. And so this is one of the reasons why you'll see coming up, we have specific protocols that we follow in the collection process. And we don't have patients chewing gum or citric acid candy as they're doing their collection. In SAMHSA protocols, they actually allow people to initially come and actually have a 4 ounces of water to either rinse their mouth out, and they can either swallow that or spit it out. But then there's a 10-minute waiting period to, again, help minimize those possible ways that somebody could try to adulterate or alter that drug concentration. Now, with oral fluid testing, a lot of the testing that we're going to be talking about today is qualitative, meaning you're going to have that presumptive positive or not detected results. And what does that really mean when you get that result back? So if you get a result back that says not detected and it's less than a certain cutoff concentration, what we're telling you is that that drug was not seen and obviously below what our detection cutoff is. So it could be right below it. If the cutoff is 5 nanograms per mil, it could be at 4, or it could be at 0, totally not there at all. But again, this would suggest that a patient did not take that drug or medication in the past day or so. Conversely, if you get a presumptive positive result back on a oral fluid, this would mean that that drug or drug metabolites, depending on what spot or analyte lights up on the test, that would be consistent with maybe that patient taking that drug in the past day or so. Remember, though, the concentrations don't indicate the time of dose or how much they took. It's just they took it within that window of detection for that drug, in this case, in oral fluid. So what types of patients populations would you actually consider using oral fluid testing for? And there's been a number of different publications by Kunkel and others that show this is especially useful in addiction populations. They found that in their study, patients tested positively more frequently when they did that witnessed oral fluid test than sending them to do an unobserved urine test. And they also found that oral fluid detected illicit drug use and noncompliance more often than the urine samples. And so this is why using that sort of a rotational strategy of sometimes using presumptive oral fluid testing along with urine testing is a good method in these addiction population patients. In another study by Petrides et al. In an addiction psychiatry clinic, they compared 263 oral fluid and urine samples in their patients. And again, as I noted earlier, some drugs are found more often at higher concentrations in one matrix over another. And in that study, certain things like benzodiazepines obviously had a higher detection rate in urine, but other drugs, for example, oxycodone, a very widely prescribed opioid, as well as 6-monoacetylmorphine, the primary metabolite of heroin, actually had higher detection rates in oral fluid. So they actually were able to capture people who were abusing heroin and using oxycodone more in the oral fluid samples compared to the urine samples. In a chronic pain management study, they also compared a number of oral fluid and urine samples. And they did analysis using LC tandem mass spectrometry for the oral fluid for 42 different drugs and used initially a urine immunoassay screening that was then confirmed by mass spec in the urine samples. And they had over 1,544 samples. The point of me sharing this study with you is that overall, The two matrices are pretty complementary, meaning there was agreement between the two. So if you found it in oral fluid, you also found it, for example, in the urine sample. And so overall agreement between those two matrices was around 85%. Um, the point being is that these types of additional matrices can actually be great things to add into rotations for either addiction medicine, chronic pain patients, when you're doing controlled substance monitoring. I will also note that as of June of 2023, oral fluid has now also been accepted for Department of Transportation and workplace drug testing programs. And though we do not do workplace drug testing programs here at Mayo, I just let you know that, again, it is an acceptable matrix that has been proven to be effective and is an alternative for collections by employers. Now let's get back to oral fluid collection and talk about some best practices or general guidelines that should be done for oral fluid collection. One of those is that we recommend that patients abstain from eating food for at least 10 minutes, ideally longer, but at least 10 minutes prior to collection. We also would prefer that they wait 2 hours if they're taking any oral or inhaled medications. We also ask patients to empty their mouth of any gum, candy, tobacco products, right? And if necessary, they can rinse their mouth out with those 4 ounces of water, of which they can either swallow or discard and spit out, and then have a 10-minute waiting period prior to collection. In this 10-minute period, this is where your mouth is naturally sort of doing a self-flushing or cleansing of itself prior to actually collecting the oral fluid sample. So now here's the exciting part. Let's talk about our new test that we're offering here at Mayo Clinic. We have an oral fluid controlled substance monitoring panel, or CSMOF, sometimes you'll see me abbreviate, in our lab test catalog and on some of the test forms. Our panel actually tests for 20 different individual analytes. You can see of the major drug classes, things like opioids, benzodiazepines, stimulants, hallucinogens, marijuana, and barbiturates. And so all the analytes and the individual cutoffs are shown here. With our testing, we also have a step-by-step sort of collector instructions that are there. All of these instructions include those best practices. So that 10-minute wait period for the patient where they're being witnessed and they have all of the gum, candy, anything pulled out of their mouth. They have the ability to do that rinsing up front. We want that 10-minute period to have passed so that, again, you have that natural cleansing process prior to the collection starting. All of this is witnessed. And then you're simply going to take the little paddle that's shown in the bottom right corner of the screen, and that goes into their mouth, and ideally with their head in a downward tilted position to, again, facilitate that collection. They basically will collect that sample. Now, most of these are going to be collected. You'll see we usually set a timer, maximum time of 10 minutes. However, there is a blue indicator strip that you can see on that pad. When that blue indicator strip is seen, that tells you have adequate volume. Essentially, that 1 ml of oral fluid has been collected, and that if it's before 10 minutes, you can stop. You don't have to wait the full 10 minutes. However, if you do not have a blue indicator at the end of 10 minutes, we still would stop collection and take that sample that is collected and put it into the collection buffer for packaging and transportation back to the lab where testing would occur. So let's talk specifically about what type of tests we are running here at Mayo Clinic in our screening methodology. We are using a biochip array technology. It uses chemiluminescence-based immunoassays. Now, the advantage of these bioarray chips is that there's 49 discrete test regions on there. So 44 of those are actually used for testing those 20 individual analytes that I mentioned earlier. And then it has 5 internal QC and visual reference spots as well built into it. This allows us to test multiple drugs and drug classes simultaneously on our patients, allowing facilitating the turnaround time and keeping a lower cost. With our tests, we also generate interpretive reports. These interpretive reports have an interpretation to help you understand what the results mean. Anything that flags positive or presumptive positive, you will see, is typically pulled to the top of these reports. And the rest of the analytes that are all individually listed will say not detected if they're not found or below that detection cutoff. As far as how is this testing sort of reimbursed and coded? This test is coded using the CPT code 80307. It is a screening immunoassay type test, and it is set up as a witnessed collection protocol. Now, how does this fit into sort of payers and CMS guidelines for controlled substance monitoring? And one of the things to note is that CMS does have some guidelines out there for the diagnosis and treatment for substance use, abuse, or dependence. And the 80307, so the code that would be used for this oral fluid testing here at Mayo Clinic, in the first 30 days that a patient's in that abstinence treatment program, that is essentially you can use that code up to 3 times in a rolling 7-day period. Compared to definitive testing, which you can only have one definitive code in the rolling 7 days. As that patient progresses throughout treatment, because remember, for the guidelines, you're going to want to do this initially and throughout treatment. Again, that 80307 code can be used 1 to 3 times every rolling 7 days in day 31 to 90 in their abstinence treatment program. And as that patient goes beyond 90 days, again, you can still use that 80307 code. However, now it's 1 to 3 times if you're doing the presumptive type tests every 30 rolling days, okay, essentially month. So this type of testing is supported, as I mentioned, both by clinical practice guidelines and CMS guidelines for controlled substance monitoring, particularly in that substance abuse and dependence addiction populations. Now, what I want to end with is how would you use this in real life and take some real clinical case studies and show you also how to interpret these results. So let's start with our first case. So this is a 45-year-old female. She has a past known history of substance abuse. Specifically, her drug of choice was heroin. She's currently enrolled in an addiction management program. She also suffers, though, from anxiety and a panic disorder. And so as a result, she is taking a benzodiazepine for that anxiety. That benzodiazepine is lorazepam, 1 milligram twice a day. As part of her addiction management and heroin addiction treatment, she is on a drug combination of buprenorphine with naloxone. And so the physician, in this case, wants to make sure she's being compliant or adherent to her program, right? So the physician wants to make sure, number one, they're taking the buprenorphine and naloxone combination, and that they're also consistent with taking their lorazepam, but they're also not still using illicit substances, aka heroin or another illicit substance. And so in this example, the physician initially actually had ordered a urine test. Again, urine being one of very common matrices. However, they get back the following results. So for this patient, they ordered a urine immunoassay test, and you can see that while it tested for a number of different drug classes, the amphetamines, barbiturates, benzodiazepines, opiates, and buprenorphine, we get the results back for this patient. Now remember though, this patient is on 2 key drugs, right? Lorazepam, which is a benzodiazepine, which we see here on the urine immunoassay is negative, okay? So not detected. And we see Suboxone, which is again that buprenorphine naloxone combination, and the buprenorphine is presumptive positive. Well, obviously this leads the physician to go, wait a second, I only see one of my 2 medications that this patient's supposed to be taking. So are they taking lorazepam? Because the urine benzoaminoassay was negative. Well, like all tests, we have to understand what does that test actually detect. And in the case of the urine immunoassay, specifically, what's that cross-reactivity of that test, in this case with lorazepam? Now, one thing to note is that most urine immunoassays tend to target oxazepam. In this figure that I have shown on the screen, everything in blue is a separate prescribable benzodiazepine. So for example, diazepam is a prescribable benzodiazepine. Then what I show with the arrows is the natural metabolic pathway of that drug. So in the case of diazepam in the center, it goes to nordiazepam to mazepam, which further break down toxazepam. Now what this means is that immunoassays that target oxazepam are really good at picking up all the blue boxes within this bigger red box, what I call the common benzodiazepine pathway. So remember though, what's our patient prescribed? Is it any one of those blue ones? No. Our patients prescribed lorazepam. And that actually gets broken down primarily, especially in urine, because we got to consider the matrix. This is a urine test that was done. And so in urine, it's primarily the metabolites that undergo phase one, phase two metabolism that are more water soluble. That's what you see in urine, not very little parent unchanged drug ends up in urine. So it's the lorazepam glucuronide that we would predominantly find in urine. And a lot of immunoassays, particularly urine ones, don't have good cross-reactivity there. So based on that, that probably wasn't the best test to order. Uh, but since we have the patient in our office now, right, we can do our witnessed oral fluid test to verify compliance. Because, as I showed you earlier, our controlled substance monitoring oral fluid test actually has a spot specifically for lorazepam. So in this case, the physician was able to collect and send to the laboratory the oral fluid result. Now, on that report that the physician would get back, you'll see that we see under the opioid spot, the buprenorphine spot came back presumptive positive, and the lorazepam spot also came back presumptive positive. And it goes on and gives a actually very detailed interpretation for each one of those. But to simplify it, the key part of that is that the drug of abuse oral fluid screen was presumptive positive for buprenorphine. Suspect that the patient has used buprenorphine in the recent past. And the second interpretation says the drugs of abuse oral fluid screen was presumptive positive for lorazepam. Suspect that the patient has used lorazepam or another benzodiazepine in the recent past. So what does this mean? Well, in this case, we have presumptive testing that's consistent with the two prescribed medications, right? The lorazepam and buprenorphine. In addition, the patient's clinical picture supports adherence. There's no other cues. There's not like this patient's going and running out of medicines, having to refill frequently, no other obvious signs of abuse or misuse. And so in the end, this presumptive testing is really all that was needed to say this patient was likely compliant and positively reinforced for being compliant. And they will continue to monitor as needed in future visits on a random basis. And so this type of presumptive testing can again provide that reinforcement and reassurance that the patient's on the right track. And again, the advantage of this, again, is because it has also that lorazepam spot where the urine immunoassays can sometimes miss that. In our second case, this is a pain management patient, a 42-year-old male who also has a history of anxiety, but has a soft tissue injury. And because of that injury, they are actually prescribed a opioid oxycodone combination with acetaminophen. And for their anxiety, this individual is actually taking clonazepam, which is another benzodiazepine. Now, using the visual analog scale, this patient's pain, so their soft tissue injury, seems to be a little bit controlled. It was originally 6 out of 10, and now it's less intense at 2 out of 10. And so this physician says, I'm going to use the oral fluid test to verify adherence or compliance to those medications, that clonazepam and that oxycodone. And so we see that this testing was ordered on our patient, and the results come back. And this time, the two things that we see light up, though, are oxycodone under the opioid classification and oxymorphone. Both of those individual spots light up as presumptive positive. But remember, this patient was also taking clonazepam. And if we look under the benzodiazepine, clonazepam, it says not detected. So what's going on? Well, we have a patient prescribed two key things that we're hoping would turn positive, clonazepam, as well as the oxycodone. And the only things that came back positive on this patient, though, was oxycodone and the oxymorphone. So this is where, again, because we are still using immunoassay, so we have to understand the cross-reactivity. Well, what does the oxycodone, oxymorphone spots cross-react with? Well, if we looked at a cross-reactivity table for these, we'll see that in the case of oxycodone, a patient who's taking oxycodone, it has 100% cross-reactivity, obviously, with the oxycodone spot, because that's what we calibrate that spot with at that cutoff or detection limit. But you'll see that oxycodone also has cross-reactivity, 160%, at the oxymorphone spot, okay? So what we typically see is in patients who are taking oxycodone, and I should note that oxycodone naturally metabolizes, so the natural metabolic pathway in the body is oxycodone actually gets broken down by cytochrome P452D6 to oxymorphone, which is also an active metabolite. And so we expect a patient who is taking oxycodone to actually show both oxycodone and its metabolite, oxymorphone, if they are compliant. Okay. And so it's what we found in our testing of patients that who are prescribed oxycodone, you will see them light up both the oxycodone and oxymorphone spots. Now, oxymorphone is also a separate prescribable drug. And so how do you distinguish that? Well, in a patient who is prescribed and only taking oxymorphone, not oxycodone, you'll see oxymorphone doesn't cross-react with the oxycodone spot. It only cross-reacts with the oxymorphone spot. And so patients who are only taking oxymorphone, we see those patients only light up at the oxymorphone spot. Just one other one to call out, because it's also a very popular and commonly prescribed opioid, is hydrocodone. And you'll see hydrocodone has some cross-reactivity as well at the oxycodone spots. But patients who are taking hydrocodone, we see hydrocodone, and typically sometimes it's metabolite hydromorphone in those patients. But in those patients, I only see the hydrocodone and oxycodone spots typically light up in patients taking hydrocodone. Now you're going, how am I supposed to remember all of these different cross-reactivities? The good news is you don't have to. This is why we built this into the interpretation fields of our tests. So in the actual interpretation fields, which actually do go across into people's EMR, it will specify, for example, it will say the drugs of abuse oral fluid screen was presumptive positive for oxycodone. Suspect the patient has used oxycodone, especially if both the oxycodone and oxymorphone spots are presumptive positive. Patients taking oxycodone commonly test presumptive positive on both the oxycodone and oxymorphone spots, and may even cross-react with hydrocodone if the concentrations are high enough. So we tell you what our cross-reactivity is right in the interpretation. So this hopefully helps simplify some of these complicated metabolic pathways and cross-reactivity questions. So in conclusion, for our case study for patient number 2, is our presumptive testing was consistent with them taking their oxycodone. But remember, we did not find clonazepam. And so how does a physician use this? They use this by having a conversation with their patient. Remember, this isn't punitive, but rather to have that positive reinforcement and conversation with our patients. And when the patient was confronted that, hey, it looks like you're only taking oxycodone and not clonazepam, they did admit they stopped taking the clonazepam because they were getting dizziness side effects that they attributed to that clonazepam, and it is a known side effect of clonazepam. And so patients tend to self-titrate themselves off medications when they experience adverse drug effects. So in the end, this patient was deemed partially compliant, so they were taking their oxycodone. Obviously, that was consistent with the information we saw on the visual analog scale as well. Remember, we don't solely just judge everything based on the single lab test, but take into account the full interaction and encounter with that patient. And the physician was able to work with the patient to find an alternative anxiety medication that did not give them that sort of side effect of dizziness and somnolence. So in conclusion, hopefully today you've seen that oral fluid testing provides another option for controlled substance monitoring. It is relatively simple, non-invasive, very easy to collect. It's also easily observable to minimize specimen adulteration, and drugs tend to be detectable in oral fluids sooner than they show up in urine. Oral fluid matrices and testing, like all tests, has advantages and limitations that you need to understand before correctly interpreting these results. Always consider things like cross-reactivity, sensitivity, specificity, complex metabolic pathways. When did the patient last take that medicine? If the patient told you they didn't take the medicine for the past 5 days, probably I would not do oral fluid testing because they basically just told you you're going to get a negative result, right? If a presumptive positive test result doesn't make sense or a not detected result doesn't make sense with the patient's clinical picture and their prescribed medication, what we would recommend is, because we do not go on and do definitive testing here at Mayo Clinic on the oral fluid, is we'd recommend the urine testing. Why? Because the minute you follow up with the patient, right, I can now go back and take that drug and then give you a new oral fluid test and test positive. We're going in collecting a urine sample at that point has that already larger window of detection. And that testing, we do have the ability to go on and do not only the presumptive positives type screening test, but do the definitive testing as well in urine. And so that would be a recommended follow-up. With all of these tests, one of the things here at Mayo Clinic that we are happy and encourage you to do is if you need any assistance interpreting these, our consultants and our reviewing tech specialists within our lab are available to call us through the MLI call center, and we can help you interpret individual testing results if needed. And with that, I thank you for your attention, and I would be happy to take any questions.
Thank you so much, Dr. Janetto. At this time, we'll go ahead and take any questions from our audience. Remember, friends, that you can submit your questions through the Q&A icon in Zoom. I'll go ahead and kick off with one. So, Dr. Janetto, you'd mentioned the stability of THC in your presentation today. Can you discuss THC breakdown a little bit further for us?
Sure. So typically with oral fluid, you're mainly going to be looking for parent THC, the parent compound. However, that's detectable in oral fluid typically 24 up to 48 hours is what most studies have shown in the literature. But THC, when consumed, obviously breaks down to a lot of different metabolic products. Within the body, it's the carboxy THC is the other sort of metabolite, again, that we see in the oral fluid. And that actually sort of extends the window of detection because that actually can be detected for several days. And so our spot actually does cross-react with both parent THC as well as that carboxy THC metabolite.
Thank you. And you'd already briefly touched upon this in the presentation itself, but is there anything else that you would like us to know in terms of CMS and commercial payer coverage and the coding and billing aspects for this test?
Sure. What I can state is that as of January of 2025, large commercial payers have been reimbursing for oral fluid toxicology testing if medically necessity is demonstrated. And for government payers, coverage is also governed by local coverage determinations or LCDs, and that's all managed by those Medicare administrative contractors. But all regional Medicare administrative contractors are currently accepting oral fluid as a biological specimen for toxicology testing. Although, just like commercial payers, coverage depends on meeting the medical necessity criteria, adhering to your coverage limitations, and providing appropriate diagnostic rationale why you're doing controlled substance monitoring. But in general, yes, oral fluid is accepted and is reimbursed for example, like I mentioned, the addiction medicine, pain medicine type population testing for controlled substances.
Thanks so much. All right, next question is on Wizinator, they sell gum that claims after chewing for 10 seconds will result in a negative test for 30 minutes. Has this been tested in Mayo to help with detection in oral fluid?
That's fantastic. So Wizinator makes both a gum and they also make a product that you can add directly to urine. And we have not tested that particular gum product. It is one of the reasons why we do recommend that sort of 10-minute wait period as a gold standard and to make sure that a patient does not have any gum or citric candy or other things that would increase oral salivation to sort of dilute out your concentration of the drug to make it fall below those detection limits. So by following best practices, that typically does eliminate some of these risks. I've also seen other products on the internet that say claim that if you take them, they consider themselves an oral cleansing agent, as they were described in the advertisement. Valsavirowid and these other sites have lots of different sections that people go to for how to beat a drug test, so to speak. We have seen those. Those don't work. We did test those, and those actually in the fine print of some of those, it actually says for best results for the oral cleansing product, we recommend you abstain from drug use or using your substance for 5 days. Well, again, that's sort of the window of detection in oral fluid, right? So you could have saved yourself the $20, $30, whatever they're charging for their product and just not use the drugs for 5 days and you would test negative as well. So in most cases, we find that these products, as long as you're following the proper collection protocols and procedures, we find that these don't interfere or impact test results.
Thank you for that. All right, next question is how does cost compare between urine and oral fluid testing?
So that's a great question. Again, this uses that 803 presumptive positive codes. And for cost and information, I would always recommend that you talk to your local sales representative, as I, in the lab, am only responsible for testing and not setting prices for these tests.
Understandable. Next question or comment and question is, we have had continuing difficulties in reimbursement for pain management controlled substance monitoring for the urines we send from both government and private payers. Even testing and the CPT timing limits are, or even though testing and the CPT timing limits are compliant. What other steps slash coding are you aware of to improve reimbursement success?
That is a great question. I do know that sometimes reimbursement is a challenge. And in that case, I actually recommend that you work closely with your own internal revenue billing cycle people, because there is special ways to code or document medical necessity. And sometimes it's just as simply as not documenting or having a certain statement to get that reimbursement. So I know even in here internally, we have our own group that can help our patients make sure they get the coverage as in reimbursement as prescribed. But it is a challenge. Sometimes I feel insurance companies take the easy route, and sometimes just the easiest thing is deny it and then make you justify it. But I know in a lot of those cases, when they figure out what that exact verbiage or things, they are able to get it then reimbursed. But I encourage you to work internally with your own billing and coding department, because they understand the tricks to get these things reimbursed either through government or private third-party payers.
Thank you. All right, next one is, what about the vaping THC and resulting? Is there a statement that explains when it shows positive in vape versus the THC that is quote unquote smoked by patients? Also, depending on the different strands of, I'm assuming THC is the rest of that question, so Delta 8 through 10.
Yeah, so they're talking specifically because there's Delta 8. Delta 9 is the common THC that we typically see. But we saw a number of products being sold to try to beat conventional testing, because a lot of labs target the Delta 9 carboxy THC as a key determination, both in oral fluid and in urine testing. So we saw people start to use the Delta 8 products as a way to, because by mass spectrometry or definitive testing, um, we specifically only would isolate those Delta 9 ones. However, we have updated all of our urine testing panels, and in the case of the oral fluid, we actually see cross-reactivity with all the different forms of THC in there, with different cross-reactivities at those spots. So we are able to pick that up. Now, the question is, can I distinguish somebody from vaping versus smoked? The answer is no, right? Because they contain THC. And so from the testing standpoint, it's THC. So I can't tell you the source. Was it from vaping? Was it from smoking? I can just tell you that THC was used within the window of detection, right, of that analyte. I can't tell you the source or how it was used.
Thank you. I believe that was our final question. So, seeing as there are no further questions, I just wanted to thank everyone for participating in today's Present Approaches to Testing webinar. When is it cool to drool? Oral fluid testing for controlled substance monitoring. If you have a question that wasn't addressed during today's session, or if you have any additional questions, please feel free to include them in the evaluation. You can access that evaluation now via the link that's included in the chat. Also, lab education credit is offered for this program. So after you finish your evaluation, you'll have the option to claim those credits and print your certificate. If you registered for this webinar and joined by phone only and you didn't receive the evaluation, please email our team at mcleducation@mayo.edu. And finally, I just wanted to repeat one last time that this program was recorded today and will be archived on our website in a few weeks. Thanks again for joining us, and have a great day.
Thank you for participating. Please click the button below to complete the evaluation and obtain credit.